Functional movement screening. What's the evidence for its use? It's becoming increasingly popular to utilize a functional screen for both the workplace and in athletics. The most popular approach is the Functional Movement Screen, or FMS, developed by Gray Cook. Yet, like most approaches to patient assessment, there needs to be a specific intention. In other words, how is the information from the screen used, and what is the evidence for this use? Since the initial introduction of the functional movement screen by Cook around 2006, numerous adaptations to its use have been created. Some include not only prediction of risk for injury in sports and in the work environment, but also prediction of athletic performance. Additionally, instead of the original description by Cook of focusing on individual scores for each movement, many have used an aggregate or summary score for prediction of risk and/or preseason screening requirement for participation. The purpose of a screen is to not miss something of importance that in most cases will increase risk to an individual. That means that it is likely that you also capture the individuals who are not at risk. Those identified by a screen are then usually evaluated with something more specific to that concern. An example would be a screen for, let's say, fracture of the cervical spine secondary to trauma. It's important to initially have a screen that does not miss individuals with a fracture so that specific testing, such as imaging, can be used to find those with a fracture. In Gray Cook's original and current description, the intention of the screen is to identify individual dysfunctional movement patterns in an effort to find issues with fundamental movement that may contribute to problems with more complex movement patterns. Additionally, it was also intended to screen for pain with basic movement patterns to identify those individuals in need of further evaluation. This means, using the definition of a screening approach, that some of the identified movement dysfunction may not be relevant, but that through further testing for those that truly have dysfunctional movement, an underlying issue might be identified and corrected. This theoretically might improve performance or reduce risk of injury. The concern is that perhaps these fundamental patterns that are tested without load are not representative of anything meaningful when compared to more complex and loaded patterns of work or sport. For example, is the squat used by a baseball catcher the same as a power lifter or the same as the dynamic squat of a volleyball player? Some would argue that the ability to hold a one-legged stand or do a lunge are not relevant to the requirements of running, a weight-bearing activity, or non-weight-bearing movements such as swimming. When addressing asymmetry, some argue that the majority of sports requires sided dominance, making asymmetry the norm and therefore not dysfunctional. The other concern is that the pain-provocative screening maneuvers that are part of the FMS are not necessarily evidence-based and are more a reflection of individual preference or assumption. There are therefore many questions in need of answers. Should the information be used as a screen for participation in sports, and if so, is it used to predict performance or risk of injury? Should the information be used for training so that dysfunction is corrected prior to task-specific instruction? And should the information be used to monitor improvement in patients' complaints, such as pain or other limitations to performing tasks? For any of these purposes and outcomes, the question is, has this been measured and applied in a study or studies to determine if reasonable assumptions about the use of FMS actually play out in real life and in context? Before any of these outcomes can be measured in a study, the application of the screening approach would need to be tested for reliability for both intra- and inter-examiner strength. One of Cook's motivations for the FMS was based on the standard practice of using a global, not individual approach to exercise prescription. He breaks these down into 3 examples. The protocol approach, which uses a prescribed group of exercises based on a condition such as low back pain. The basic kinesiological approach, which is based on anatomical or physiological knowledge related to function of a muscle or group of muscles. And the prehabilitative approach, which is to train athletes proactively based on known injury patterns common to a specific sport. His concern is that individual dysfunction is subtle and complex, and that by not identifying each individual's dysfunction, the practice of a generalized approach to exercise may embed and hide this dysfunction, potentially reducing performance or increasing risk. So what is FMS? The FMS is an approach to asymptomatic individuals as well as symptomatic individuals to examine, rate, and rank movement patterns to discover and correct limitations to specific movement dysfunctions or asymmetries. These dysfunctions may reveal problems with, in particular, mobility or stability and relationships to proprioception. So we'll attempt an overview description of the FMS and literature support for its use. This presentation is not intended to teach the FMS approach. So the FMS assessment is not about strength, endurance, or skill training, but it is about alignment, mobility, stability, and functional proprioception. The sequence of approach to each individual would then be to focus on movement competency with the FMS, and then progress to physical capacity, and then to skills related to a specific sport or activity. In relation to load, this means that movement competency is assessed first without load. Static and then dynamic load are part of the next steps of physical capacity testing and skill testing and training. A key concept is to find the pattern with the most limitation or most asymmetry and remediate this weakest link. The reason may be joint restriction, muscle tightness, poor segmental stability, or a combination of these. In scoring movement for the FMS, pain equals 0 and means that that movement test has failed, requiring further evaluation as to the cause of pain. Said another way, there are divisions based on elements of pain and no pain dysfunctional patterns. Dysfunctional non-painful movement is called the path. These are generally mobility and/or stability problems. Dysfunctional painful movements are called the markers, which require further testing, including orthopedic, neurological, and joint-specific evaluation to arrive at a diagnosis of cause and result in an approach to management. There are two sequential components of the FMS. One is directed at the asymptomatic individual and is called a functional movement screen. This approach is not diagnostic. The second approach for symptomatic individuals is called the Selective Functional Movement Assessment, or SFMA. This approach uses more patterns broken into component elements to determine a cause of pain or dysfunction. The scoring for the FMS is simple, with a 0 or 1 rated as failure and a 2 or 3 as a pass, essentially a dichotomous pass or fail system. This is important when considering whether some scores are scientifically valid. If there is pain, the score equals 0, and the screen for that movement is over. A score of 3 equals a movement pattern that is complete and consistent. A score of 2 equals a movement pattern that is completed, but demonstrates compensation, loss of form, or loss of alignment. And a score of 1 equals a movement pattern that is not completed and was not performed consistent with the FMS test definition. There are 7 basic movements of the FMS. Further breakdown of the FMS is into the big 3, which are considered functional patterns, and the little 4, which are considered fundamental movements. Components of the big 3 are the deep squat, the hurdle step, and the inline lunge. Components of the little 4 are shoulder mobility reaching, active straight leg raising, trunk stability push-up, and rotary stability. For 3 of the 4 movement screens, there is an additional clearing exam. This is not scored, but is used after the movement screen to detect pain. If there is pain, the score for the movement is 0. The 3 tests are the shoulder mobility reaching test, the trunk stability push-up, and the rotary stability test. The sequence of approach is to first correct problems with the fundamental patterns found with the little 4, then correct functional problems next found with the big 3. Then correct split patterns, which include the hurdle step, lunge, active straight leg raise, shoulder mobility, and rotary stability, and then progress to addressing straight or symmetrical patterns. The SFMA is used when pain is felt with screening movements of the FMS. All of the following have breakout movement assessments, including the evaluation of the cervical spine, upper extremity, multi-segmental flexion, extension, and rotation, single leg stance, overhead deep squat, and rolling patterns. Now that we have an overview of FMS, its criticisms, and the questions regarding its use, let's investigate the literature. We need to be careful here because it's easy to combine these studies into a broad group of FMS articles. when in fact each fits a specific category in relationship to the reliability, validity, and utilization of FMS results. First, is the FMS reliable? There are currently 13 studies on inter-rater reliability and 8 studies on intra-rater reliability. All report on the sum score for the FMS, not individual movement ratings. The FMS demonstrates on average good to moderate reliability. Specifically, good to excellent reliability was found for the push-up, quadruped, shoulder mobility, straight leg raise, squat, hurdle, and lunge. Next, what influences the FMS? Studies demonstrate that either an explanation of the scoring system, exercise, or time can change the FMS score. On average, an interval between 15.4 and 15.9 out of a possible total of 21 seems to be consistently found in studies establishing normative values. This is not a baseline to reach, simply an average. As we'll see, this is close to the threshold for risk established by other studies, indicating on average many individuals would be at risk. Yet the risk appears to be around 15% if 14 is used as the threshold. Does the FMS score predict athletic performance? Of 8 studies that assessed a relationship between athletic performance and FMS sum scores, only 2 have found any correlation. In one study, the FMS appears to have minimal capabilities for identifying movement deficiencies that could affect multidirectional speed and jumping. Others require at least one other sport-specific evaluation in combination with the FMS for it to be of any value. Does the FMS score predict risk of injury? Out of 11 studies, 7 determined that a sum score for predicting injury is 14 or less out of 21. 4 of the studies found that the FMS could not predict injury, and one study indicated that the odds ratio for injury in athletes was 4.7 times higher for those scoring less than 17. Other studies found a 4-fold increase in risk of lower extremity injury in female collegiate athletes using a score below 14 as the threshold, and a 4-fold increased risk in military trainees when combining a score of less than 14 and running time. For football players, the strongest individual indicator of risk was a low squat score. What if the screened individual who scores high represents someone who is either a better athlete or less prone to the risks related to dysfunctional movement patterns, and as a result has longer exposure times to the other risk factors of sports or work, such as contact injuries and other non-dysfunction-related accident and injury? Stuart McGill points out that similar to the worker environment, exposure time is an element that must be considered. He states that one study did in fact find that those with higher FMS scores had a higher rate of injury, but explains that this is due likely to the increased exposure time that might be related to their higher performance level. So where is most of the research coming from? Well, mainly 4 researchers, as we'll see: McGill, Frost, Beach, and Callahan. Here are some examples. In the Journal of Strength and Conditioning Research, published in 2012, was the article Using the Functional Movement Screen to Evaluate the Effectiveness of Training. FMS scores were examined before and after 12 weeks of training. No significant differences in the total FMS scores were found for any group post-training. In 2013, in the same journal, FMS scores change with performers' knowledge of the grading criteria. They conclude that because knowledge of grading criteria affects the FMS score, the FMS may not always represent dysfunction. Then in 2014 in Ergonomics, Physical Fitness Improvements and Occupational Low Back Loading. There were 2 groups of firefighters performing different exercise programs. Following a 12-week training, FMS scores and occupational low back loading measures were not consistently affected. And in Applied Ergonomics in 2014, FMS scores and low back loading during lifting. Using an injury prediction threshold value of 14, the summative FMS scores were not related to the peak low back loading magnitudes in lifting. So what about other approaches to movement testing? Well, certainly the FMS is not the first or only functional testing approach. For example, with regard to risk prediction, the STAR excursion balance test has been found to be a good predictor of lower extremity injury in high school basketball players and seems to correlate with the FMS scores in one study. Even McGill, Liebenson, and others use different functional screening methods. For example, in the past, McGill et al. Established a 4-test screen for risk of low back injury, which included the plank, sit-up, back extension, and extension hold. More recently, McGill proposes a different group of movements that include the squat and lunge, but also include a lift, pushing, pulling, gait walking, stair climbing, crawling, twist, and a twist with torque. He also discusses categorizing into unfit and moving poorly versus unfit and moving well, and fit and moving poorly versus fit and moving well. Liebenson suggests the magnificent 7 functional screen, which includes active lumbar range of motion, the wall angel, overhead squat, single leg balance, single leg squat, lunge to kneeling and return, and respiration. Obviously, all of these are constructs built primarily on experience and logic, and to a lesser degree scientific evidence. But they all have the same goal of screening for poor movement and finding corrections at the level of basic fundamental and functional movement patterns. Well, some questions for the future. As with all testing, we need to know why we do the test. It can't only be an organized and well-practiced ritual that instills confidence in the patient and examiner, but needs to actually provide meaningful, impactful information. Defining what that information is and how it's used is crucial to avoiding ritual. And remember, everyone is different with different needs. For example, in the work environment, if one were to construct a project to establish baseline information for all individuals regarding their FMS scores, how does the future healthcare history of those individuals relate to this baseline comparison? In other words, is it applied to all employees, regardless of the manual labor component of their work, regardless of their outside exposure to risk involving recreational activities, and of course, normal life activities? Those confounding factors are difficult to control or compare. Most importantly, how is management of dysfunction standardized so that comparisons can be made? For example, when pain is found with a specific movement or screen, if one practitioner uses manipulation only, another myofascial work, and another taping and exercise, or if a single practitioner uses these approaches as an individualized menu approach, meaning that different individuals with the same problem are managed with different management approaches, how can comparison be made? As McGill implies in his 2012 paper, there can be different approaches to reducing pain in patients with low back pain even though they seem similar. And if so, how can a standardized approach to all low back pain be compared and evaluated for effectiveness? The same may be true with correction of dysfunctional movement. Finally, is the FMS a self-fulfilling prophecy, meaning finding dysfunctional movement patterns and correcting them only improves the FMS? If the correction is transferable and valuable for prediction of risk, for example, there must be a comparison between those with, let's say, a threshold of 14 or below, used as a criteria for creating an intervention group, and a control group with the same score but not remediated. If those with uncorrected low scores have higher injury rates than those that don't, then perhaps correction of dysfunction has value. So, as attractive as a functional movement screen is, there must be some caution in extrapolating its value beyond what is known. It may be that this individualized approach that will vary among practitioners makes standardized studies of effect impossible. Given that possibility, those that use an FMS should compare within their own practices and track approaches based on findings to provide meaningful comparisons within the context of that practice. This means, though, that the demographics, diagnosis, comorbidities, outcome measures, and management approaches of those individuals need to be captured for comparison. A goal of software engineers should be that EHR software should be designed with these types of in-practice study approaches in mind, with an overarching goal of comparing among those using the same data capture programs.